Good afternoon. Welcome everyone to the Senate Committee on Health and Human Services. Madam Secretary, please proceed to call the roll.
Senator Lang?
Here.
Senator Nguyen?
Here.
Senator Stone? Here. Senator Titus?
Here.
Chair Doniate.
And I am here. Thank you so much. Well, good afternoon, everyone, and welcome to today's meeting. Today we have two presentations and two bills. One of them was taken off the agenda, so I just wanted to make sure that everyone knew that we were going to have two bill hearings today. Before we start, I do have several housekeeping announcements. So the goal is to start off with our presentations and then move on to the bill hearings, since the bill hearings are our committee members. So we're going to start off with the Gwynn Center first, then the University of Nevada Reno Latino Research Center, and then we'll move on to the bill hearings. We ask that if folks have public comments to, of course, please keep that to 2 minutes each, especially for those that would like to testify in support or opposition for the bills. You can also submit your comments in writing to the committee staff. And of course, we ask that you sign in at the beginning at the front of the room. When testifying, please turn your microphones on to speak and off to listen. And of course, make sure you reiterate your name. And anyone who wishes to receive copies of the committee's exhibits can go to the Nellis website, and you can also receive it from our committee staff. And then last but not least, we ask everyone to please turn off your electronic devices. So that way we can proceed with the meeting. So let's go ahead and start off first with the presentation from the Gwynn Center. So today, it's an honor to welcome back Assemblywoman Tolles, who is the Executive Director, and of course, Mr. Michael Stewart, the Interim Research Director from the Gwynn Center. So please proceed when you both are ready.
Well, thank you so much, Jill Tolles with the Gwynn Center, for the record, and Chair Doniate, it's wonderful to see you here in this role. We work together on the interim for the Substance Use Working Group, and members of the committee and friends and colleagues. It's great to be back. I'm here to just talk about an update of where the Gwynn Center is at, where we've been, and hopefully open the dialogue for many more conversations in the future, as we hope to be a resource to your committee and to this legislative body. So once again, my name is Jill Tolles. This I count as chapter 3, maybe, in my time here in the building. I served 3 sessions as an advocate, and then 3 sessions as an assemblywoman. And now I am pleased to be the executive director of a nonpartisan statewide policy research center. So I wanted to give you just a little bit of background. Are you able to see? Okay. If you're not familiar with the Kenny Gwynn Center for Policy Priorities, it was founded as a 501c3 in 2014. And it came together as a result of a group of dedicated Nevadans who saw a need for independent and nonpartisan think tank that served our entire state and the increasing needs of our ever-growing population. And our board is made up of Democrats and Republicans. We seek very intentionally to make sure that we represent all ideological backgrounds, experiences, industries, and to address the pressing topics of the day in our state. We are data-driven. We are independent in nature. We, again, are nonpartisan, and we're statewide. We are affiliated with the University of Nevada, Reno. We are housed currently in the Innovation Center, but we have researchers in Las Vegas and in Reno, subject matter experts across the state. We have collaborations and research partnerships with UNLV and UNR. And for those of you who may not know or don't remember, we are named after our namesake, Governor Kenny Gwynn, Nevada's 27th governor, who is known for knowing the budget backwards and forwards, known for being a champion of education, and for the ability to work across party lines. So why the Gwynn Center? I feel like this picture illustrates oftentimes our experience. where you might have two individuals looking at what they think are the facts. One person sees that there are 3 bars on the ground and the other person sees that there are 4, depending on where they're standing. And I don't know about you, but I feel like I experience this on a daily basis, where oftentimes we are given certain facts or only certain research or only certain information from the viewpoint that we're standing in. And that the most helpful way to see the whole picture is to widen the lens, to see all the information, to land on the best decision. I care about this work because I've sat where you sit. I know how incredibly difficult it is. I know how oftentimes you're hearing from so many different constituencies and groups, bringing forward information from a specific perspective. And it's important to be able to do your job based on the best facts and the best data that you possibly can, so that you can serve this state well. And so our team is in the process of continuing to expand. After COVID and several different directors for various reasons, good reasons, in fact, we were founded by Nancy Brune, who did an incredible amount of work in the initial years. And then when she stepped away to serve in public office herself as a city councilwoman for Las Vegas, Dale Urquiaga came on board to be executive director and then was soon tapped to be our NSHE chancellor. Dana Bennett, who some of you may know from the halls of the legislature, formerly with LCB, and then the Mining Association, took over as interim. And then I stepped into this role in January. And so with a number of those changes, it's been an opportunity to come into this organization and build off of the legacy of great work that's been done before, but also to rebuild everything from our strategy to our team to our processes. And some of you have asked, how do we manage our team as well as our funding? So you'll notice here that I've got 2 branches of the House in the organizational structure. The Green Branch with an assistant director who will be coming on board in April to handle operations and outreach and fundraising. And our administrative side is separate from our research side. One of the first things that I did was divide out the business operations and the funding side of the house from the research side of the house, so that there was an inherent separation between the two, so that we can ensure that the researchers are focused solely on the research, not where money is coming from or chasing down those dollars. In response to some questions that I've received about where our funding comes from, in the first few years of the Gwynn Center, it was primarily philanthropically funded, mostly in part by our board members who wanted to see a nonpartisan independent think tank in our state. And over the last few years, we've taken on more contracts. Most of our funding actually comes today from state and federally funded contracts and our philanthropic arm. And so we're going to continue to focus on broadening that to be able to answer the questions that you're asking in this sessions, and also to be able to look at the bigger picture questions with unrestricted funding in the areas of education, the economy, health, natural resources, tax policy, budget, and so forth as they arise. So I want you to know that that's one of the first checks that we've put in place to make sure that the research is independent. Some of the additional checks that we're putting into place in our strategy is to make sure that we have steering committees and a team of advisors through our advisory council that are with us from the beginning of the research project all the way through to the end. So they will be coming from different perspectives, from various subject matter expertise, to help instruct the questions that we're asking, to make sure that we're asking the right broad questions. And then at the end, we are going to put our research through a vigorous peer review process to make sure that even if people may not necessarily like the outcomes of the research, that they can stand behind that this is fact-checked and that it has been thoroughly vetted. And we want to make sure that when we come before you, that anything that we bring with that Gwynn Center stamp of approval has been through that thorough process. So on the research side of the house, we have now soon passed the baton to our new interim research director, which we are very excited about. We have a current team of researchers both in Las Vegas and in Reno. And then we contract out with faculty from UNLV and UNR and other subject matter experts. We have graduate students that work on that, and we're soon building out an internship program. This is where I envision us heading as we continue to build out our staff and contracts with some of the smartest brain trust in our state. We will continue to work with faculty, grad students, subject matter experts, interns, even looking at a fellowship program in each of our key categories in the state. So this year, we're focusing mostly on building out that strategy, rebuilding that team, and expanding on our existing very talented team and our funding. And then next year, you're going to see more of the production of that research. We do currently, and I'll have our research director talk about this in a moment, we do have research that we are doing today, and we are publishing some of that research, but you're not going to see as much from us in this session as we are completing those research projects. You're going to start to see that more in 2024 through research papers, policy briefs, fact sheets, ballot explainers, and then out of that, when appropriate, recommendations for policy action. And then in 2025, you'll see us promote that work to the public, the executive branch, the legislature, and our local entities. So with that, day one, I moved us into the Innovation Center, and I think day two, I reached out and after having conversations with a very, very extremely talented former face that you would recognize, our retired research director for the Legislative Counsel Bureau, Mike Stewart. It took a few coffees and a few breadcrumbs to help convince him to come out of retirement and come on board as our interim research director. I will say for him, and he can elaborate on this, but one of the most important things in that initial conversation at a Starbucks was that we both are big fans of LCB and the work that the staff does here in the building, and that it was really important to know that we want to be a resource that LCB could turn to as they're providing their briefs to you, and not competition in any way. And I've personally picked up the phone call and talked to the directors to say that I would not poach any of your current staff, but the retired staff is available for all the poaching. So I was quick to jump on that, and I am so grateful to introduce Michael Stewart, the very talented former research director for LCB.
Well, thank you very much for that introduction. For the record, I'm Michael Stewart. I'm the interim research director for the Gwynn Center. It's interesting to say that and being on this side of the microphone. I think last time I was on this side of the microphone, we were presenting reapportionment plans as the staff. So I'm excited to be in this role. And as like other probably former LCB employees, we have a hard time retiring. So here I am. We're back, and the beauty about this role is, nonpartisan work kind of gets in your blood if you're in this as long as I was, and so to have this opportunity to work at the Gwynn Center was really exciting. So, and as Jill said, we are just so excited to be partners, not only with your staff, but with university systems, with other organizations, with policy institutes statewide. We've done some great meeting tours with our partners at UNLV and partners at your community college system and also at UNR. And so we feel that there's a great brain trust there that we can connect with as we're doing our work. So it is a very collaborative process that we're engaging in. And so we're very, very excited as we move forward in this rebuild phase. And as Jill mentioned, you're going to probably see more of us as we kind of approach the 2025 session and we really kind of build out on our research. But she did mention we are working on a few projects currently, and we're working in sort of the economic policy space with a workforce participation study. We're pleased to have partnered with the UNLV's Center for Business and Economic Research on that one. We've got a few things going in education policy with regards to out-of-school youth, a partnership with the Nevada Department of Education on some needs assessment and looking at some per-pupil funding and how that overlays with various types of school, school functions and Title I schools versus high SES schools, heavy PTA work, and how the pure people funding sort of overlays with those inputs. And also working with the Children's Cabinet on some early childhood work. We've got some sort of governance policy going on right now. We have our wonderful Director of Economic Policy, Meredith Levine, working on a budget explainer that we think should be helpful for you. And then on the social policy side, looking at housing challenges for those with intellectual and developmental disabilities. And we just wrapped up also in partnership with the Grant Sawyer Justice Center, did I get that right? And also the UNR School of Social Work, a human trafficking study. And we're looking to expand on that too with hopefully some federal funding. So we are still busy doing that sort of work, but like I said, we'll be ramping that up in the next 12 to 18 months and probably have more for you then. But again, I'm excited to be here. The partnership opportunities are vast, and we're very excited. And we want to be a resource for you, your staff, and the other brain trusts that we have in the state. So I think with that, I'll just turn it over and offer it up for any questions at this time.
Thank you so much. If we have any questions from committee members, I think Vice Chair Nguyen has one.
Thank you. And you guys look fantastic. It makes me wonder if I made poor choices. But it's always exciting to see you guys all here today. And I'm really excited about the prospects under your leadership, Assemblywoman Tolles, as well as you, Mr. Stewart. I'm just really excited about this. How are you determining what kind of policies and what kind of research and what kind of areas that you're going down? Like, is healthcare in the realm of possibility to have policy research come out of that area?
Jill Tolles for the record, and yes, that would be one of the key areas that we want to build out our research team to have some deep dive studies for you in the interim, as well as short explanation summary briefs. And one of the things, I'll jump ahead to maybe the next question you might ask, because it's one of the things that I wanted to offer up as next steps, is to get input from each one of you. Our main audience is 63 plus the executive branch, right? And find out what kinds of things would you like deep dive, independent, original research done by Nevada researchers in our Brain Trust of NSHE in this state to be able to provide back to you. So stay tuned. We will be following up with you to ask for input on what you would like to see researched. And then additionally, we have an advisory council and that we're continuing to build out to ask what are some of the most pressing issues in our state. And then we'll filter those down and look at the expertise on our staff and what we will be able to get done before the next session and then beyond.
No, I'm really excited about this. I know that as legislators, and I know you know this, a lot of times we will turn to LCB, and they are a great resource. And just during the interim, I know there are a lot of outside organizations that we turn to, like CSG or NCSL. So the idea that we have kind of the homegrown talent, homegrown like research, and it's coming from Nevada, based on Nevada, and it's like specific to Nevada and how it might be implemented here. I'm really excited to see the work that comes out of the Gwynn Center.
Thank you so much. Any other questions for our presenters? I think we're good. Thank you so much. We appreciate you coming down by. We'll go ahead and go on to our next presentation. Very excited for this one. I went ahead and invited the University of Nevada, Reno's Latino Research Center. So we have with us Dr. Sanchez to present on the status of Latino health. So Dr. Sanchez, whenever you're ready, please.
we go.
Good afternoon. I'm Jafet Sanchez. I'm the director of the Latino Research Center at the University of Nevada, Reno. It's a pleasure here being with all of you, Chairman Doñate and committee members of the Health and Human Services. And I appreciate having been invited to this. I was born in Mexico. I grew up in Yerington, so I'm a proud product of Lyon County School District. And I look forward to being able to share information regarding health issues for our Latino population. A little bit about the Latino Research Center. We are nearing our 20-year existence since it's first opened its doors. We have focused our mission on these 4 areas that you see here. Something that has at times taken a bit of a back burner has been the research collaboration and the research endeavors. And so my vision for the Research Center is for it to serve as a pillar of Latino research so that organizations like yours and other entities can really use it so that our findings, discoveries, impacts, everything will help to benefit social cultural outcomes, whether it's Nevada or beyond. The aims of this presentation, though, will focus on demographics related to Latino Hispanics, centering a little bit more on healthcare. And of course, that's in brief because we know that can be very exhaustive, and then narrowing in on some aspects of our Latino Research Center efforts. So for our Latino Hispanic demographics, we are approximating the 1/3 of our population having this identity. That's a 2.2% increase. And it doesn't seem like very much, but when we look at the individual, it's really 175,000 additional people that we need to serve and we can help through health access. In Nevada specifically, the state has the highest birthplace diversity across all other states. So that is an important marker for thinking about how we serve our community and how we look to the future of serving this community. When we focus on that in education, we see our higher education roughly mirroring that proportionate percentage of the population at 31.6%. But in the K-12 setting, that's actually much larger. So you see we're approaching that 50% in the very near future. And so when we look at these population increases, that also comes with more disparities, unfortunately, when it comes to access to healthcare. 50% of U.S. Hispanics have reported that they have less access to quality medical care. And then when we look at preventative care, we also see that they're less likely than their American counterparts to receive that care. So again, think about the preventative care side and then look at the 43% of our students in K through 12 already who are beginning at these levels further behind on their access to have this improved quality of life. When we look to the future, they ultimately end up at higher rates being in jobs with increased risk for health problems. So I wanted to begin with highlighting a key point that focuses on the Latino aging population. For those demographics, they face greater challenges in the aging process. So when we think about discrimination, they do face a double jeopardy standard when it comes to their age and their racial ethnic identity, and then tying it back to healthcare. They also live in higher poverty rates as compared to the non-counterparts, and you can see that's a pretty large discrepancy there in terms of how that the rates differ. And so in turn, they have these more negative influencers on their health outcomes. In terms of just the general population in Nevada, when we look at Latinos and Hispanics, we see the top 3 areas that are the leading causes of death. The first one that you see, health disease, I will say that that's actually the leading cause across all racial ethnic demographics, which I'm probably preaching to the choir here, but I just want to make it known that that's also the case for our Latino Hispanic population. And then when we look at that third one, diabetes, it is often linked back to obesity. So again, a lot of things that we can really help to remedy through some healthcare improvements. Another part that I wanted to highlight is self-medication for illness. I know that there are a lot of PSAs right now in our state to support this endeavor, but we still see a massive need for what we relate to self-medicating and the direct relationship that is tied to access to healthcare. Many Latinos are transporting antibiotics, and that's because they see that it's not affordable or it's not available. So those are things that, again, from your point, if we're able to identify some remedies to prevent this, then we're able to help reduce what we see as resistance to drugs that later means they don't have the quality of health that they deserve. As high as 56% have reported on some studies accessing antibiotics without a prescription to doctors and with doctors, and you can see that that's a massive, again, discrepancy with their counterparts. Now, if I think back to that 43% of what we see in K through 12, for early diagnosis for Latino children, they have prevalent barriers with a diagnosis specifically to the autism spectrum disorder. The rates, as much as 3 to 4%, can really hinder their trajectory into those next pieces of higher education, linking it back to even those challenges that we're seeing with our aging population. This is surmounted with other factors that we see for transportation, access to services, and then also their economic and legal status. And again, the ongoing health concerns that they're seeing with coverage. So if they're not having this diagnosis and they're not receiving the information and support that they need, then their lack of services in turn is resulting in different behaviors that are obviously not, valued in school systems, and therefore, unfortunately, they end up facing more disproportional aspects in relation to disciplinary procedures, which we all know then in turn lead to more negative consequences down that educational trajectory. So they do also in Nevada offer few services and delivery models or interventions that help to support the Latino students when they are identified on this spectrum, which in turn means that for the Latino population, their needs are not being met at the same level as others. And in Nevada, there are only 2 out of every 3 children who have this need are supported. That is also coupled with longer wait lists. So our population, who is often part of the low-income family background, they then wait longer as compared to those who maybe have a private health insurance and quicker access to those things that sometimes many take advantage of. And I would be remiss in my short time that I have with y'all if I didn't mention behavioral health concerns. When we think of the United States population as a whole, more than half of adults with a mental illness do not receive treatment. This can be as high as 27 million individuals who are awaiting support. When we look at Nevada specifically, those discrepancies on identifying whether they need support are very varied. That has to do with some things such as who the population is being served, who is being identified as Latino Hispanic, how they go about seeking their participants and things like that. So while a lot of factors come into play, there's still a massive need, again, when it comes to behavioral health concerns for this population. They do seek primary care support, but it's often for somatic symptoms. And so in reality, it's often a manifestation of those depressive symptoms. In Nevada, in a very recent study, it was found that Latinos had lower rates of the prevalency for depression. But this is coupled with what's long in the literature been said that cultural norms might influence how they're identifying their symptoms. So for example, as a Latino who maybe is constantly crying, they might say, oh my gosh, does this person have depression? But if they're not sleeping well, they might not associate that as the same way as being part of a depressive symptom. And so those tend to influence also what our rates are for the need. It's estimated as being much higher, and in some studies it's estimated as being much lower. But again, it shows that there's a need to really explore this more in depth and center it on the work of Latinos in Nevada. Again, while I'm preaching to the choir, perhaps it's really important to think about this demographic under the overall vulnerability index that the CDC provides. So if we just give a quick glance at these, we can see that our population for Latinos, Hispanic, they really do hit so many of these points that just unfortunately end up emphasizing those barriers that they experience. And so I just want to bring note to, beginning with that child all the way through that aging group, how often they end up having these barriers being something that have to be overcome, and how important it is for our centers and our organizations to bring light to this need so that we can better serve our communities. And as an education background or field of expertise for me personally, we talk about that as opportunity gaps, and I argue that in healthcare it's the same thing. It's not that Latinos, Hispanics simply have poor health by default of who they are or their gender, race identity. It's really that they haven't had the same opportunities to access for healthcare to improve upon that health quality that we all want to see and that our entire state can benefit from. So that begins with access to healthcare coverage, dissemination of knowledge, which in turn means that they can have more access to the resources that they need. And one of those largest resources is representation in the healthcare setting, whether it's entering into one office to seek healthcare, or whether they visit a Facebook page, which we see Latinos using more often now as a way to seek information. And then I want to end with the increased cultural and language adaptations. Sometimes it seems like it can be a huge, robust endeavor, but it can also be, again, when the person walks into a front door to seek support, that someone there resembles who they are, or if nothing else, at least understands their cultural context, connections, and allows them to bring more meaning to their experience, which in turn leads to more opportunities for them to seek health and then be able to have that healing that we desire in our state. So what is the Latino Research Center doing on these endeavors? I've only been in this position for a year, and so I just want to preface it with that. And as of this January, I am dedicating more time to this work, thanks to our institution at the University of Nevada, Reno. But this is not meant to be an exhaustive list. I just selected the things that are really healthcare related, which I'm hoping that, come to mind for you of more value in this particular focus. But the Community of Bilingual English-Spanish Speakers, it's a CBES grant-funded endeavor. We're on our 5th year. We had 120 students that we started supporting in the high school level, and we've pipelined them into higher education to support health and STEM fields. And then we are in the process of having another round of this grant get approved. Fingers crossed, maybe within the next month we'll know. It's roughly $1.2 million. And ironically, it's actually in Lyon County, so it'll be a nice shift from supporting an urban setting to now focusing on the rural needs of our state. The Latino Housing and Health Study, this is in partnership with the Department of Geography and the other entities you see, their community research leaders and our center. And that one is underway, so the hope is that we'll support community forums, dissemination of information, and it includes more than 400 families across our northern Nevada region in terms of what they're facing during housing instability and their health needs. And then the other ones, again, this is not meant to be exhaustive, but I wanted to just note a few where in each of these instances that you see listed here, we're either supporting them with evaluation needs, helping to distribute studies or surveys, and in other aspects we are collaborating to see how we can help them reach the Latino community, whether it's through advertising, whether it's through the different personal and professional connections that I have with our community members, and having some and other pieces. We are actually just really helping to form community forums where they have identified some findings, and they're using our Latino Research Center as a means of reaching the community in a very, engaging manner. So a lot of work going on, but lots of fun things. And I echo my colleagues here from the Gwynn Center, hoping to collaborate on some more endeavors together because our aims are really so in line. So I do thank you all for the opportunity to speak today. And if you have any questions or comments, I'm happy to entertain them.
Thank you so much, Dr. Sanchez. If any committee members have any questions, I will go ahead and ask. Okay, so I want to go back to the slide on opportunity gaps. In talking about health equity, I think this is an important slide for all of us to visualize because we know that there are efforts that we can do for not just in terms of health literacy, which is what we saw during COVID, but also like what does cultural and linguistic resources look like, especially for certain populations that might not have the same standing place as others. And perhaps the most important part, which is what my question will be for you, is the first one is access to healthcare coverage. And what we've noticed, at least even in recent times, I received a report on my desk just a few hours ago, which laid for me the district demographics of, at least for Senate District 10. And it showed to me that in my district, the Latinos that comprise my residents, that 25% of them are uninsured. So what are some of the trends that you're seeing in terms of healthcare access, and why do so many Latinos in this state lack healthcare coverage?
I was actually trying to identify some items for that. I haven't had the chance to explore that yet, but I will say that percentage of roughly 25% is accurate in terms of what we're seeing across the country. When we look at our 44 million population across the United States, on immigrant population, about a quarter of those are undocumented, so that might also be a linkage. But I know personally I have family members who are documented and different things like that and struggle with the trust and the mistrust that comes with healthcare access, and oftentimes it's call a person and then they'll help you and they're not sure who they're calling if they want to share information with these individuals. So on an anecdotal way, those are some of the things that I would, suggest exploring through focus groups and other means, but I can't, confirm that right now.
Thank you so much. And I think I think from my personal perspective, I appreciate the work that you guys are doing to collect data points on this, because there are metrics that we've seen nationally, and not just in this state, but nationally, that there are segments of the population that don't have access to care. And I think that's something that we have to have discussions for the legislature. And I think particularly with this population group and others, the Latino population is a significant portion of the state. It's about 1/3. And the issues that they experience are not just Latino issues, they're Nevada issues. And I think that's something that we have to curate. And I think with your presentation, with the delayed care that we're seeing, that can impact the social determinants as they move on in later life. And so I appreciate you for detailing as to some of the research efforts that you have been doing. But if any committee members don't have any questions, I think we appreciate your guidance, and we look forward to collaborating with you. So thank you so much for joining us here today.
Thank you all. Thank you, Mr. Chairman.
All right, let's go ahead and move on to our next agenda item. We'll go on to Senate Bill 241. I will go ahead and open the hearing on Senate Bill 241. This bill revises provisions relating to Medicaid. With us today, we have Dr. Titus. So Senator Titus, please proceed when you are all ready.
Hello, Chair Donante and members of the Nevada Senate Committee for Health and Human Services. I am Senator Dr. Robin Titus. I represent Senate District 17, which includes all of Douglas, Lyon, Churchill, Mineral, and Esmeralda counties, and part of Nye, specifically Tonopah. Thank you for allowing me to present today SB 241. The bill before you today concerns our critical access hospitals, of which there are only 13 of them in the state. 4 of these are in my Senate district: Banner Churchill Community Hospital in Fallon, Carson Valley Health in Gardnerville, Mount Grant General Hospital in Hawthorne, and South Lyon Medical Center in Yerington, which is why it was important to me to bring forward this legislation this session. We provided the committee with a Medicare Learning Network piece on what a critical access hospital is, as well as what swing beds are. And we're happy later on, if there's still some questions, we'll address those on those specifics. SB 241 itself is straightforward. Section 1 requires that Nevada Medicaid to pay these critical access hospitals at their cost for providing outpatient services and swing bed services to Medicaid beneficiaries. Currently, Nevada Medicaid does this for all critical access hospital inpatient services, but not outpatient services. This will come at a cost to the state, which will hopefully be discussed in Senate Finance later in the session. But the policy here is important to these hospitals. Pursuant to 42 CFR 14, the Center for Medicare and Medicaid Services, which I will refer to as CMS, reimburses critical access hospitals at cost for Medicare beneficiaries for both inpatient and outpatient services, including swing beds, and allows for state Medicaid programs to do the same. CMS does this because they realize it is vital to these small rural hospitals to keep them open and providing services to their communities. Cost-based reimbursement does not make a profit for hospitals, but acknowledges that they also should not be taking a loss for providing services to our Medicare and Medicaid recipients. They are simply being paid for what it costs them to provide services in their community, and it does not include any costs of physicians or other professional services. In any given year, about 25% of critical access hospitals in Nevada have a net loss in operating revenues. This bill will go a long way in ensuring we don't have any of our critical access hospitals in Nevada at risk of closing, and that they remain in the communities providing access to care for all of our Medicaid beneficiaries. Chair Donate, with your permission, I will now turn the presentation over to Joan Hall and Blaine Osborne with Nevada Rural Hospital Partners to discuss it further. Thank you.
Thank you, Senator Titus, for bringing this bill. Chair Donate and members of the committee, for the record, my name is Joan Hall. I am the president of the Nevada Rural Hospital Partners, a position I share this year with Blaine Osborne as he's replacing me when I retire at the end of the year. NRHP was formed in 1987 with the sole purpose of maintaining access to hospital-based healthcare services in rural Nevada, something that still is our purpose. SB 241 is a very important policy that will assist in preserving access to health care for rural Nevadans and the sustainability of our critical access hospitals. With the chair's permission, I would like to allow some background and historical information on critical access hospital type, as we have different conditions of participation and conditions of payment than other hospitals that you're aware of. This will be provided by Dr. John Packham, who is also one of our colleagues. He's joining us by Zoom today. And then I will provide information on the types of services provided by these 13 hospitals. And finally, Blaine will finish up by talking about financial information. So Chair, with your permission, Dr. Packham is on by Zoom.
Please proceed.
All right, good afternoon, Chair Donate and committee members. For the record, I'm John Packham, Associate Dean for the Office of Statewide Initiatives at UNR Med. I appreciate the opportunity to join you remotely to provide a brief overview of the Critical Access Hospital Program in Nevada, as well as a little background information relevant to Senate Bill 241. As you'll hear in greater detail from my co-presenters in a moment, SB 241 would direct our state's Medicaid program to amend the state plan for Medicaid to allow for cost-based reimbursement for outpatient and swing bed services received by Medicaid patients in critical access hospitals. Excuse me. Critical Access Hospitals, or CAH, is a designation given to eligible rural hospitals by the Centers for Medicare and Medicaid Services, or CMS. Congress created the CAH designation through the Balanced Budget Act of 1997 in response to over 400 rural hospitals that closed in the late 80s and early 1990s. Since its creation, Congress has amended the CAH designation and related program requirements 11 times through additional legislation. Currently, there are 1,358 CAHs throughout the United States in 45 states, including 13 in Nevada. The CAH designation is designed to reduce the financial vulnerability of low-volume rural hospitals and to improve access to care in keeping essential services in rural communities. To accomplish this goal, CAHs receive certain benefits, including primarily cost-based reimbursement for Medicare inpatient and outpatient services to rural residents. Eligible hospitals for this designation must be located in a rural area and meet the following conditions to obtain that CAH designation. First, they must have 25 or fewer acute inpatient beds. They must also maintain an average length of stay of about 4 days or 96 hours or less for those acute care patients. They must also provide 24/7 emergency care or ER services to their community. Finally, they must be more than a 35-mile drive from the next hospital. That is, they are almost by definition the most isolated among rural hospitals, or they must be more than 15 miles of drive if there's a mountainous terrain or secondary roads to that facility and the next hospital, such is the case with Incline Village Community Hospital. In that same Balanced Budget Act of 1997, Congress also created the Medicare Rural Hospital Flexibility Program, or the Flex Grant Program, to support new and existing critical access hospitals in Nevada and other U.S. states. The Flex program provides federal cooperative agreements to states to help them achieve their strategic goals and provide technical assistance and support for quality improvement in those facilities, financial and operational improvement activities, and then finally, population health and EMS work that serves their critical access hospital communities. The Nevada Flex program is our state's version of the larger federal program. It is housed in the Office of Statewide Initiatives at UNR Med. My office has overseen the Flex grant program and the critical access hospital designation progress in our state since 1999. To date, the Nevada Flex program has received a little over $12 million to support a wide range of technical assistance to our state's 13 critical access hospitals, with about 40% of that being subcontracted to my friends and colleagues at Nevada Rural Hospital Partners. Since 2001, when Nevada designated its first critical access hospital in Hawthorne, Nevada, that's Mount Grant General Hospital, COD designation has been a game changer and has helped stabilize rural hospital financial performance and improve the economic viability of those facilities across our state. Indeed, I would dare say that the Medicare cost-based reimbursement received by those facilities has literally kept the doors open in a couple of our most vulnerable rural hospitals over the past 2 decades. An important piece of unfinished business is how critical access hospitals are reimbursed by state Medicaid programs. In establishing the COD designation, and like many features of state Medicaid programs across the country, Congress pretty much left it up to individual states to determine how Medicaid will reimburse CAHs. Over the past decade, every CAH hospital in Nevada has experienced a growth in the number and proportion of patients with Medicaid coverage. What SB 241 would accomplish is to provide or allow those same low-volume, remote rural hospitals to receive cost-based reimbursement for all services provided to Medicaid patients, again, as it currently does with the patients who receive Medicare coverage. In summary, Senate Bill 241 represents an important opportunity to address the financial headwinds currently faced by our state's rural hospitals and to ensure access to essential healthcare services for our state's 300,000 rural and frontier residents. I'd happy to entertain any questions you have for me, or we can defer until Joan Hall and Blaine have finished their presentation. Thank you.
Joan Hall again for the record. I've provided you with this map that we think tells, I think pictures tell a million words. And looking at this map, you can see that the rural hospitals that John is speaking of, our critical access hospitals, we provide care in 90% of Nevada's landmass, only to 10% of the population, but it's a huge area. You can also see the distances from the nearest urban Nevada hospital. And those average, if you average that, it's over 100 miles. But you can see from Ely, it's 242 miles. From Winnemucca, it's 166 miles. So that's a long distance for patients. If those hospitals weren't there, it's a long distance for patients who are there and need transportation to a tertiary facility. Because as John said, we can only keep patients an average length of stay of 96 hours. So if they need a higher level of care, we have to have transfer agreements with all of our urban hospitals to accept these patients. This map also shows the distance of each of these rural hospitals from each other, as well as the urban centers. All of these hospitals, as John said, have to have 24/7 emergency service. These hospitals vary in size. We have 2 hospitals that only have 4 acute beds. We have 6 that have the maximum of 25, and it varies in between. 7 of these hospitals have a distinct part long-term care associated with the hospital, and those are the only long-term care facilities in their communities. So you can imagine the important role that plays in a community. Only 5 of these hospitals have an intensive care unit. Only 7 provide surgical services. 7 also only provide the only lab and imaging in their community. There aren't outpatient labs, there aren't outpatient diagnostic centers. the hospital is the only place you can go for lab or x-rays. Sadly, and not unlike what we see in much of rural America, we only have 3 critical access hospitals that provide OB services. That is Fallon, Winnemucca, and Ely. That is, like I said, not unlike rural America. 60% of rural America communities are without OB services, something that is a very sad thing in my mind. 11 of these 13 hospitals operate rural health clinics. The only primary care in their communities typically is provided by these hospitals through the rural health clinics. 11 of our hospitals have swing bed. You've heard that designation. It's a special designation CMS has allowed for rural hospitals, not just critical access, but any rural hospital, to use their acute bed as a long-term care for this skilled part. So you have to have had a 3-day hospital stay, and you need a skilled service. So, and the expectation is that you'll return to your post-hospital stay health. So it's intensive IV therapy, physical therapy, speech therapy, occupational therapy, getting people to return back home. 7 CAUS are public hospitals receiving tax support from their counties. They have elected governing boards. They're subject to the open meeting law, the bidding process, and the public works process. 5 are part of larger systems, and 1, Boulder City, is a sole nonprofit hospital receiving no extra support. With that, I'll take any questions on services offered or not offered by our hospitals, or turn it over to Blaine to talk about finances.
Thank you, Chair Dunyate and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. I just want to touch on a couple of additional points very briefly. First, outpatient service volumes are increasing in our critical access hospitals, including in emergency room services, where our hospitals see the highest numbers of Medicaid fee-for-service patients. In 2010, President Obama signed into law the Patient Protection and Affordable Care Act, which, combined with Nevada's decision to expand Medicaid enrollment, reduced Nevada's uninsured rate and grew Nevada's total number of Medicaid beneficiaries. The COVID-19 pandemic has had a similar effect, and Nevada's rural counties now total more than 69,000 Medicaid beneficiaries, which equates to fee-for-service Medicaid outpatient encounters as high as 30% in some of our critical access hospitals. Secondly, in an attempt to offset low Medicaid rates, Nevada Medicaid offers a number of supplemental payment programs. Unfortunately, due to eligibility requirements, 3 of our critical access hospitals received no supplemental funding whatsoever. Additionally, the outpatient upper payment limit program benefits only 7 of the 13 critical access hospitals. And although those hospitals are very grateful for that benefit, it still comes at a cost to them, as they have to provide intergovernmental transfers in order to participate. And the total payment that they receive under that supplemental funding is less than the amount that they would benefit from under Senate Bill 241. Albeit small in relation to the whole Medicaid budget, this change in reimbursement represents a significant amount to the hospitals and the communities they serve. To ensure access to health care and to keep providers serving the neediest areas in Nevada, I appreciate your consideration of Senate Bill 241. Thanks.
And finally, this is Joan Hall again for the record. Nevada Critical Access Hospitals are the safety net providers in some of the most remote areas of this state: Battle Mountain, Caliente, Ely, and Hawthorne. In any given year, 1/3 to 1/2 of these hospitals have net operating losses. The tax support received for the 7 district hospitals is what keeps them open. Net proceeds of mining for the mining communities has greatly enabled those hospitals to build better infrastructure and have more equipment. Net proceeds is not eligible for everybody, is not eligible for net proceeds, so those hospitals are fortunate. We've also recently been fortunate that the Helmsley Trust has selected Nevada Rural Hospitals as an organization they want to support, and they recently replaced most of our imaging equipment. So we're very grateful to that. Pennington Foundation, also in northern Nevada, has assisted hospitals. I tell you this because operations don't allow these rural hospitals to invest like these organizations have given to us. The closure of any rural hospital has devastating effects on the community. Hospitals are usually one of the top 3 employers in their community. Losing emergency services would stress our already strained EMS system that we have. It's very fragile in rural Nevada. The hospital-based long-term care loss is horrible for those patients and their families to have to travel hundreds of miles to visit. And the longer distances in travel for critical or trauma patients, the loss of the golden hour can't be understated. Simply put, without these facilities, there would be no access to care in that rural community. The citizens of Tonopah have stories to tell about the impact of the closure of their hospital, and that has had on lives and well-being of many. We appreciate your support and consideration of this bill for these communities and for the state of Nevada. Thank you very much for hearing it.
Senator Donante, Chair, we do have members of these hospital directors here today to testify. They can testify now, or they can come up and support when it comes to that. Otherwise, we're done with our formal presentation. Thank you. And we're entertaining questions.
Yeah, I think if we can go ahead and move on to questions, and maybe they can do it in support, since I think it'll go fairly quickly. I'll start with my question first, and then I'll go to Vice Chair Nguyen. So actually, during the presentation, I pulled up a report from the Department of HHS nationally, and it said that Medicare could have saved billions at critical access hospitals if swing bed services were reimbursed appropriately. So this is a timely conversation. That came out in 2015 from, looks like it was the Inspector General, so 2015, March of 2015. I guess my question would be, I started poking around and seeing if other states have done similar practices. I think I saw Texas as one of them. Have you noticed other states? Is that something that you've done in your research of mimicking similar practices to support our rural hospitals, or what's some of the research behind the proposal?
Yep. Thank you, Senator. Blaine Osborne, Nevada Rural Hospital Partners, for the record. At least as it comes to the outpatient cost-based reimbursement side of SB 241, about 18 other states have gone this direction, providing cost. I don't know what the total number of states is on swing beds, but we could get that information for the committee.
Thank you. Joan, did you want to say something?
Thank you. Joan Hall for the record. Just, I think a point of interest when you talk about what other states have done. Nevada only has 13 critical access hospitals. Kansas has 84. Texas has, I don't know, a huge number as well. So 13 is one of the lower numbers of critical access hospitals. Montana, I think North Dakota, other places with large land mass and not a lot of people probably have about the same number as Nevada does.
Thank you so much. Vice Chair Nguyen.
You actually took my question. I was just going to ask how many people had that cost-based reimbursement model, and that was it. I know that the rural hospitals have been struggling, so I really do see this as a good solution.
Any other questions? Senator Stone?
Well, first of all, thank you, Senator Titus, for bringing this bill forward, and thank you for your service of being a rural physician for most of your career and dealing with, these hospitals, some of which don't even have OBGYN services. This has been an enlightening hearing for me as I look at this map and I see the value of the 13 critical area hospitals that if you just lose one, you're talking about somebody not getting the health care that they need and deserve. So it's also very disturbing for me as an elected for so many years, hearing that a hospital only strives to break even. God forbid they should make a profit to try to keep the doors open, especially for the amount of uncompensated care that many of our hospitals utilize. So just a few questions, and maybe this is to you, Dr. Titus. So you have somebody, let's say, that has a stroke, they get into a hospital. Under your bill, they're going to be entitled to getting 100% of their cost and taking care of that stroke victim, but if there's beds available in that hospital, they can get some ancillary care, physical therapy, et cetera, and be reimbursed. Is there a time limit on that period of time before they have to go into a SNF or they're able to go home?
So at this point, we can only keep them 4 days in the acute side, and then we either have to put them in that swing bed or transfer them to another facility.
Okay, and so and I would assume if somebody is really serious, I would assume that there is some helicopter services or emergency services that gets them to UMC or some hospital that can accommodate their healthcare needs.
Right, Senator Titus, for the record, yeah, it depends on how far away. Our helicopters can only fly a certain distance. We were fortunate when I practiced in Yarrington to be able to have the helicopter land. I've ridden it. I know it takes 27 minutes from our back door in Yarrington to Reno. I also, in my clinic in Smith Valley, had a little helicopter pad there, and I could get those helicopters. They were stationed in Gardnerville, and they could be there in 17 minutes. And believe me, sometimes we were watching that clock. Further out, however, would require a fixed wing because a helicopter just can't transport that further. So that's what you would make the arrangements with, depending on what the conditions, the lighting. And frankly, sometimes nothing flies, and I've done CPR on somebody for an hour and a half driving in an ambulance to town. So it depends on the situation.
I appreciate it. And just one more question, if I can, for Dr. Packham. Dr. Packham, thank you very much for your testimony today. You've really educated me. But can you just compare and contrast the FLEX program versus the program that we're trying to do today? I'm trying to understand the differences in the funding and what they go towards.
Yeah, John Packham for the record. Real quickly, there's a critical access hospital program that oversees the designation of rural hospitals to that critical access designation. The FLEX program, think of as a technical assistant program that's been ongoing since 1999. In the early days of that program, we focused most of our energy on preparing rural hospitals for that survey, getting them ready for a review of their conditions of participation, and so forth. Over time, we focused more on strategies and measures to, again, help them stabilize their finance and operations. But there's the critical access hospital designation part of what we do, and then now primarily technical assistance to those same facilities.
Thank you so much. Any other questions? I think we're ready to move on to testimony. At this time, we're going to go ahead and start with testimony in support of this bill, and then we'll move on to opposition and neutral. Just a reminder to please keep your remarks to 2 minutes each. We do have fellow executives from our rural health system here, so come on down and please begin when you're ready.
Good afternoon. My name is Thomas Mayer, spelled M-A-H-E-R. I'm representing Boulder City Hospital and speaking in support of Senate Bill 241. Boulder City Hospital is one of the critical access hospitals that's closer to an urban area, obviously in Clark County. Last year, we were unable, and therefore we did not accept almost 600 Medicaid referrals for the year from the urban acute care hospitals for their patients needing subacute placement in our swing beds due to the incredibly low rate of Medicaid reimbursement. We can be a better partner to our Clark County urban hospitals and increase access for life-saving medical intervention if we can receive cost-based Medicaid reimbursement for the subacute transfers and free up those acute care beds for sicker patients. As been said before, critical access hospitals are what the name implies, healthcare facilities that fill a critical need for access, especially in an emergency. Our patient volumes are relatively low, but our presence is essential. Cost-based Medicaid reimbursement gives us a fighting chance to take care of our rural communities, and that doesn't even begin to address the need for improvement in our physical plant, equipment, and infrastructure. Federal law requires that we treat and stabilize anyone who arrives in the ER, regardless of resources. Currently, we receive about 11 cents for every dollar of cost to provide these services, and this is not sustainable. Thank you.
Good afternoon. Jeff Prater, CEO of Carson Valley Health, for the record. Thank you. In addition to our 23-bed critical access hospital, Carson Valley Health has 6 outpatient clinics that are located in Minden, Gardnerville, and also in Topaz Ranch. I come before you today in support of SB 241 in order to positively impact access to care within our service area It's important this bill move forward. Our patients, like many other rural areas across the state, want access to health care close to home. In our last audited financials, which was 2021, Carson Valley Health incurred costs for outpatient Medicaid patients of $4.2 million, of which we were reimbursed $1.7. Included in that 4.2 is approximately $500,000 to provide outpatient orthopedic services to the population, to this population of patients, because we're not also reimbursed for implants, which is the reason they're getting the surgery itself. Carson Valley Health also provides swing bed services within its 23 licensed bed. Our swing bed costs are currently $2,825 per day, only $210 less than our acute care stay. So you may ask, why? Is that the reason? Well, first, we don't employ separate nursing staff solely for swing bed patients. Therefore, our nursing staff may have a patient load that has both acute and swing bed patients. Second, it must be noted that while a swing bed is a change in patient status, it may not qualify for acute status. A majority of swing bed patients have a nursing acuity equal to an acute care patient. Medicaid currently pays $128 for swing bed services, which is $2,697 less than our cost per day. Thank you.
Good afternoon, Chair Donati and the members of the Senate Health and Human Services Committee. I am Denise Ferguson. I am the administrator for Mount Grant General Hospital in Hawthorne. And I am in support of SB 241 for a lot of the same reasons that have been indicated today, which is that if we do not exist, the landmass and the people that we would support would be devastated. This is a significant issue to our hospital because 33% of our hospital ER visits are Medicaid beneficiaries. And 16% of all other outpatient services that we currently provide to patients are currently holding Medicaid. Our hospital serves the needs of Mineral County, and for the past 6 years, we are also serving the needs of Tonopah due to the fact that their hospital closed. The tragedy that we see for these patients coming to us in critical need is staggering and sad. Our hospital serves the needs of a rural footprint, and if this bill was to pass, it would allow us to provide continued access to service but expand services. So as we say, our par is to honestly almost be at, income neutral. The biggest access to care in our community, at least for us, is transportation. So just getting patients to come in for preventative care is difficult because they don't have that need. And to get them out of our community is even harder. If we had any income, probably the very first thing we would invest in is transportation. Currently, there is literally no transportation going outside of our community or getting patients back to Tonopah. Currently, if Tonopah patients come to Mineral County to seek care in my ER or for outpatient services, we are personally paying to have them transported home. I appreciate your time today. Thank you.
Anyone else in Carson City at this time? Come on forward.
Good afternoon, Senator Donati and committee members. My name is Jason Blake, spelled B-L-E-A-K. I am the administrator and CEO from Battle Mountain General Hospital, and it's a pleasure for me to be here today to speak in favor of SB 241. First statement I want to say is my staff and I love to provide care to our rural community. We enjoy it. We have spent a lot of time learning and becoming professionals, and we want to be strong and healthy in our rural communities. As you have heard, there's a lot of statistics out there. I'm not going to restate any of those statistics, but I'll tell you about Battle Mountain. We serve a very large land area, but we have 6,300 residents. 20% of those are Medicaid patients. Our nearest hospitals to us, one is 50 miles away, one is 70 miles away. One of those hospitals is also a critical access hospital, and they are likely going to be in support of this bill as well. As stated, this will help us maintain some stability and some viability. It allows us to reinvest back into our staff, into our medical imaging technology, also into our standard of care so that we can continue to advance the level of care that we provide. And it also allows us to stabilize one of our largest cost centers, which is the emergency department. The passing of this bill will further the work that has been done by our federal government in CMS by helping stabilize Nevada rural critical access hospitals. Thank you.
Good afternoon. My name is Patrick Kelly. I'm the CEO of the Nevada Hospital Association, and we support Senate Bill 241. Critical access hospitals are the heart of healthcare in rural Nevada, and we all know that we need to keep our hearts strong and healthy, and Senate Bill 241 will do that. We urge your support. Thank you.
Mr. Chairman, Dan Musgrove with Strategies 360, here on behalf of the Valley Health System of Hospitals, which is very proud to have Desert View Hospital in Pahrump, Nevada, as a part of one of our hospitals, and ditto to all that's been said. It's a very important part of that community, and we support this bill. Thank you so much.
Good afternoon, Mr. Chairman and members of the committee. Sarah Adler, today representing the Nevada Advanced Practice Nurses Association. NAPNA is in support of SB 241. It is their mission to create access to health care, and of course, if we lose any of our rural critical access hospitals, we're going in exactly the wrong direction. APRs are major healthcare providers in Nevada's rural hospitals, and putting on an old hat of mine, I used to finance rural hospitals as the state director of USDA Rural Development. Our hospitals cannot get low-cost, long-term loans from the federal government unless they show a revenue stream to repay that loan. So if we can take this step with our precious Medicaid dollars, we can bring in more federal dollars to improve facilities and equipment in rural Nevada. So thank you.
Thank you so much. Anyone else in Carson City, in Las Vegas, and virtually?
If you would like to testify in support of Senate Bill 241, please press star 9 to take your place in the queue. Caller, you are unmuted and may begin.
Good afternoon, Chair Danyate and members of the committee. For the record, my name is Robin Dunkhorst. I'm the CEO at Humboldt General Hospital in Winnemucca, Nevada. On behalf of the underinsured rural residents of Humboldt County, I thank you for this opportunity today to testify in support of Senate Bill 241. To serve and provide thorough access to care for Medicaid patients in our community, it is paramount that critical access hospitals be paid for the cost of the delivery of outpatient care and swing bed services. Not only do we sorely lack the resources for mental health, but primary care resources are limited in most areas, and most rural counties are a primary HIPSA. If you want to improve the disparity of health care in rural locations, it needs to be a priority to ensure that access of care in this area is supported by paying for the cost of the care that is delivered, so we are able to afford to develop services and offer at minimum rapid and effective access to primary care. With escalating inflationary costs and healthcare labor shortage issues, now is the time to offer this level of subsidy before we start to experience possible closure of some rural organizations, similar to the tragic recent closure of Desert Springs Hospital in Las Vegas. Unlike most industries, healthcare cannot pass the increased costs on to the consumer, which is not a bad thing, but does indeed cause healthcare delivery instability in rural organizations that have nothing left to give. If this bill does not get moved forward, I foresee my organization having to look at tough decisions like closure of services of the behavioral health clinic, cardiology clinic, obstetric services, and our rural family residency program, just to ensure that we keep the heart of our life-preserving needs intact. These are just a few of the many services we offer to improve the access to adequate health care that every rural resident deserves, regardless of their ability to pay. And you can help ensure that that grows and improves. All I'm asking for today is that we're paid at the cost for the services we're already delivering. We're not looking to make money here, but simply break even because it's vital to our sustainability. Thank you for allowing me to speak today, and I urge you to support this bill.
Caller, you are unmuted and may begin.
Good afternoon. I'm Brandon Shattuck, spelled Chaddock for the record. I have the privilege of being the administrator of Pershing General Hospital and Nursing Home. Pershing General is the sole healthcare provider in Pershing County for primary care, emergency care, diagnostics, and long-term care. We are located an hour away from other healthcare services along I-80. Nearly a decade ago, the hospital almost shut down, and while much effort went into their financial turnaround, their story is not unique. Unfortunately, many critical access hospitals face similar challenges year after year, operating on slim margins that hinder physical plant, equipment, and service line reinvestment. Rural hospital closures are increasing nationwide, but Nevada can reverse this trend by adopting innovative approaches like SB 241. Supporting this bill would help PGH stabilize its facility and reinvest in services. Over the past year, we've added certified wound care and explored a mobile rural health clinic in partnership with the county to care for underserved and rural populations that are typically Medicaid or Medicare. Even though the physical assets are already available for the mobile clinic, the administrative burden to get through the state's application process is costly and time-consuming. We're doing the very best we can with already slim margins. In 2022, our audited total margin was negative 8.3%, primarily due to cost of labor and supplies. Because Medicaid members represent 15% of the patients we serve, reimbursing those visits based on the cost to provide them care would allow us to strengthen our core services, improve our aging building and equipment, and better address community health needs. Thank you for your support.
Good afternoon, committee. My name is Tony Inserra. It's Inserra. I am the administrator of South Lyon Medical Center in Yerington, Nevada. South Lyon Medical Center provides health care to the rural areas of Smith Valley, Mason Valley, and the surrounding communities of Mason, Schurz, and Topaz Ranch Estates, a population of over 14,000 lives. With very low commercial payers, South Lyon Medical Center relies heavily on reimbursement from Medicare and Medicaid. Our facility treats many retired individuals as well as thousands of low-income families. We are proud to come from a rural mindset, continuing to focus on farming, ranching, and small business. SLMC is proud of its commitment to provide up-to-date diagnostic equipment to ensure these services are available regardless of a patient's ability to pay or lack of transportation. We have been committed to rural health care for more than 70 years, and this bill will ensure our ability to continue to provide care in the future. Medicaid pays our facility significantly less than our costs for outpatient services. Our costs for these services are 36% of the billed charges, but Medicaid only pays between 9 and 11%. For example, in our last fiscal year, ended March 2022, we billed Medicaid just over $3 million for combined outpatient emergency services and were paid just $261,000, which was $827,000 less than our cost to provide the services. And in the 11 months of our current fiscal year, ended March 2023, we billed Medicaid just over $3.4 million for combined outpatient and emergency services and were paid just $409,000, which is $827,000 less than our cost. I would urge the committee to support Senate Bill 241. Thank you.
Hello, I'm Matt Walker, Administrator at White Pine County Hospital District in Ely, Nevada, and I'm calling in support of SB 241. We are a critical access hospital with the nearest tertiary hospital 230 miles away. So it's about a 3.5, 4-hour drive to the nearest tertiary hospital from our facility. I don't want to repeat everything that's been said, although I will state that we have the same issues and concerns that have been already commented on. I'll give you a real quick, real-life example of decisions that we face here in Ely. We have a number of patients who don't have adequate transportation or the means to get to a higher level of care for some heart therapy that they might need in a cath lab. And so what we've done here is we brought a cath lab to Ely in order to support that care. And what we found is we had a number of patients who were able to access that care that otherwise were unable to access it, and they were able to receive life-saving procedures. Well, because of the just low reimbursement that we see with Medicaid, which is about 20% of our patient population and about 8% is uninsured, we're now trying to make a decision on whether we can continue to keep this service because we take such a loss that it makes it difficult to continue, and we need to keep our doors open for all the other services that we provide. That could be extrapolated to a number of other services, but that's just one real-life example of what we've done here in Ely with the cath lab that has made a tremendous difference to our community and our community members. So I would like to, again, just ask you to support SB 241. Thank you for your time.
Good afternoon. This is Melissa Rout. For the record, ROWE, I am the administrator at Grover C. Dills Medical Center in Caliente, Nevada, and I support Senate Bill 241. Just a little overview of our facility. We are 39% Medicare and 25% Medicaid. From those numbers, the direct impact on our critical access facility receiving cost-based reimbursement for outpatient services would be significant. Access to care in rural Lincoln County is also important to note, as this is a community that is underserved, aging, and we provide primary care to our elderly population who cannot leave the county. We also serve a wide and diverse group of visitors to this area who come to enjoy outdoor recreation, state parks, biking, hunting, fishing, and off-road enthusiasts. We also provide medical services to our Caliente Youth Center and our Pioche Conservation Camp. I would strongly urge you to consider passing SB 241. Thank you.
Caller, you are
Hello.
unmuted and may begin.
Hello, I am Robert Carnahan, CEO of Banner Churchill Community Hospital in Fallon, Nevada, and we are in favor of and support SB 241. As you know, Fallon is in Churchill County, and even though Churchill County is a population of about 25,000 people, we geographically serve probably another 10,000 more constituents besides what's here in Churchill County. As far as like outpatient cost-based reimbursement goes, this will definitely allow us to provide Medicaid patients the coverage that they need and the care that they need. Currently, our Medicaid mix is just over 20%. In a realm where private hospitals have a choice to provide care to Medicaid patients, critical access hospitals help to fill the gaps to continue to offer care for these patients, especially in the rural areas. Access to care is super important. I'm a nurse by trade, so when it comes to care, I want all patients to receive the best care they can. This is especially noted at Banner Churchill Community Hospital. Obviously, we provide one of those hospitals that provide ICU. We have ambulance service here that covers over 5,000 square miles. And then we also have one of the 3 OBGYN services in a rural facility. So we provide that community, surrounding communities, and we also support the Naval Air Station Fallon. It's been a struggle to recruit providers. That's another piece of this. It's hard to cost for clinicians and providers is skyrocketing right now. The pool is limited, which makes it more harder to get those providers and clinicians to the rural areas. That cost impact on hospitals because of this shortages obviously has increased. Also to mention, like others, the cost of supplies, pharmaceuticals, and capital. Banner Churchill has been a really great steward of our community. And here over the past few years, we actually contributed a $10 million investment into a new emergency department, again, related to those increased outpatient services that there's a need for. We've also added a new $2.4 million MRI, and even some of those not so clinical items, like we had $1.3 million for a parking lot replacement. So there is just so much cost that goes in that people, I think, a lot of times don't understand, like the costs that go into running a hospital, and like even as simply as a parking lot, so people can get in and they're not tripping over fissure lines in the parking pavement. So there's all these considerable costs that we have to be good stewards of. So having outpatient cost-based reimbursement will certainly help our efforts to provide high-quality care and that continued access for all. Thank you.
Chair, there are no additional callers in support at this time.
Thank you so much. Let's move on to opposition. There's no one in Carson City, anyone on Las Vegas, and neutral. Oh, sorry, not neutral. Anyone virtually.
Chair, there are no callers wishing to provide testimony at this time.
And let's move on to neutral. Anyone in Carson City, Las Vegas, and virtual.
Chair, there are no callers choosing to provide testimony at this time.
Thank you so much. Senator Titus, did you have closing remarks?
Senator Dr. Robin Titus, for the record, I just appreciate all of you hearing this bill. As you know, it is near and dear to my heart. You heard from all of the folks that I have represented and all the passion throughout the state from north to south and east to west, and we all agree that critical access hospitals are critical to Nevadans. Thank you very much.
Thank you so much, Senator Titus, and of course to our healthcare executives that either tuned in virtually or joined us in person. We know that you have very busy lives taking care of our most vulnerable patients, and we appreciate all the efforts that you do for this bill and beyond. So thank you so much for joining us. I'll go ahead and close the hearing on Senate Bill 241, and we'll now move on to opening the hearing on Senate Bill 280, sponsored by Senator Nguyen. This bill revises provisions governing contraception, so please begin when you're ready.
Good afternoon, members of the Health and Human Services Committee. I appreciate you hearing this bill today. We will hopefully be brief. I'm Rochelle Nguyen. I represent Senate District 3, and I'm bringing to you for your consideration Senate Bill 280. And it was brought to me by this woman, this wonderful and smart, intelligent woman next to me. And so I am going to turn it over to her. I will say that we received this bill, I think on Thursday. It was introduced on Thursday, and I received it on Thursday. And we have been in contact with a lot of the stakeholders, so we will be working on some of the legislation. But I think the policy conversation is where we'd like to begin our presentation for this committee today. So I will turn it over.
Yes. Hello, Senator Donati and Chair Donati and the rest of you. It's nice to be here today to talk to you all. I'm Sandra Koch. I'm an OBGYN, and I've had the pleasure of practicing obstetrics and gynecology here in Carson City since 1990. It's an honor to be here today to talk with you about this bill. which, if passed, could significantly improve access to long-acting reversible contraceptives, known as LARCs, for women in the hospital setting. Access to LARCs after delivery has been hampered by the lack of these devices, both IUDs and implants, in hospitals. Hospitals in Nevada do not carry these devices. Although Medicaid in Nevada reimburses for these devices, providers can't place a device that isn't available to them. Access to LARCs, LARCs are the most effective reversible contraceptive on the market. They have the highest continuation rate for reversible contraceptives. 70% of pregnancies occurring in the first year after delivery, which are referred to as short interval pregnancies, are unplanned. Just very unfortunate. These short interval pregnancies are at higher risk for preterm delivery and adverse neonatal outcomes. Placing a LARC in the delivery room is more effective at reducing this rate than delayed placement at a follow-up visit following delivery, especially for those at the greatest risk for unplanned pregnancy. Although the use of LARCs within the hospital for unrelated health concerns would be smaller, unrelated to pregnancy, it is also of great importance. LARCs are effective tools for preventing pregnancy in women with health conditions that place them at high risk for complications if they were to get pregnant. They're also effective for reducing excessive uterine bleeding, anemia from excessive bleeding, uterine pain, hysterectomy, and cancer risk. There is a role for their use in the emergency room, the operating room, and admitted patients. The medical community in Nevada is seeking your help in order to provide access to the national standard of care, long-acting reversible contraceptives within the hospital setting.
I think that kind of summarizes it, and we are prepared for any questions you might have.
Thank you so much, Senator Nguyen. Any questions? Senator Titus.
Again, thank you both for being there, and thank you for presenting the bill. My one concern with this, and I certainly support conceptually having that and being able to get reimbursed for it, is all those rural hospitals that you just heard from that don't do OB, and that if somebody comes in and has a precept delivery, of which I have been the catching end of those, would you expect that all of those hospitals would have these devices available when perhaps the person receiving that baby is a PA that's never caught a baby before? Would you expect them, if that patient asked, to insert one of these?
Rochelle Nguyen, for the record. That is one of the things that we are talking about, how we can accomplish what our goal is. One of the things is even in Senate Bill 280 as introduced and as we're presenting it today, it is very limited in the type of long LARCs that are potentially required. So we've been already talking about what other types of devices might be included in there to give some flexibility to not only doctors that are doing it, whether it's a shot, it's a copper IUD, it's an IUD, there's a lot of different opportunities and options. So we're going to continue to have those conversations on how we can address that. But I will say that we would love for it to be in these rural communities where there is a lack of access to healthcare, and if this is a preventative type of birth control that it's available when someone gives birth, then we can prevent unwanted or unplanned, I should say, pregnancies, or both.
Yeah, and thank you for that, because I certainly agree with that, but the expectations of perhaps an intermediate device may not be reasonable in every location versus having a shot versus some offering of some sort of birth control. I certainly accept that. I mean, I certainly understand that, but it also has to be within a reasonable amount, and I think you'll hear maybe from the rural folks about that too. Thank you.
Thank you so much. Senator Stone.
Thank you, Senator Nguyen, for bringing this forward. I think it's a great bill. If you are inserting an IUD outside of delivering a baby, it's not exactly the most pleasant experience for a woman. Usually, a woman delivering a baby has had an epidural, and so that they maybe won't feel the pinch, if you will, and having these proven items inserted to prevent them from getting pregnant, because the minute she leaves the the hospital, she's still fertile. She could become pregnant days after delivering a baby, which is not impossible. But I assume that a woman would probably make a request that, hey, listen, I'm going to have this baby, and you know what, I want to wait before I have another baby. While I'm there in the hospital, can we go ahead and have this inserted? I assume she'd have to sign a document to that effect.
We certainly accept verbal consent for that, but there are, exactly how that consent would be given. I'm sorry, for the record, this is Sandra Koch.
Yeah.
And what I was going to say is, this would probably be planned in advance for most people, but the highest risk population often haven't received prenatal care. So they're in the hospital and they deliver a baby and they decide at that point they don't want another pregnancy. It's a perfect opportunity to give them either an Nexplanon, an implant in the arm, or to place an IUD in the uterus, which is already huge, so it doesn't even hurt to put it in at that time.
Right, so long-term progesterone implants, right?
Long-term progesterone implants or an IUD would be just perfect in that setting.
So if we can just focus on IUDs for just a quick moment. Dr. Andrea Chisholm, she's the director of OBGYN in Cody Rural Healthcare in Cody, Wyoming. She cited a statistic that said that there is a 27% risk of IUD expulsion if it's implanted at the time of delivery. I didn't know if you had any comments on that. And one other thing that was a warning is that because you have uterine inflammation after the birth, that there is more of a chance that you could actually have a uterus lesion by puncturing it, and that requires surgery. So I'm just wondering, because this is not a risk-free procedure, especially after pregnancy, would it be appropriate to at least warn or give the patient the statistics that this could possibly happen if she wants to get that device right after delivering a child?
For the record, this is Sandra Koch. And in response, what I'd like to say is, actually, if you look at the data, there is an increased risk of expulsion of IUDs after placement following delivery. However, if you look at 6 months and you look at the use of long-term, or look at IUDs at 6 months, and you compare the people who were able to obtain it in the hospital versus the one who, there's a randomized study, and if you look at the group that got them in the hospital and the group that was randomized not to get them in the hospital, the number of women who still had them at 6 months was a third bigger than the ones who were supposed to get it as an outpatient, because many of them never even came in for a follow-up appointment. So when you look at the overall benefit, it's significant. The risk of infection, I have not seen any data to say that there's an increased risk of infection or perforation. So those are the two things you were discussing. Thank you.
Okay, I appreciate, I'm fully support, but I like looking at medical data, and I just wanted to relay that as a concern, but thank you for bringing it forward.
Thank you, Senator Stone. Quick question. 2 parts. Number one, don't physicians already mention the risks of a certain procedure before a patient asks for? Is that not standard practice anyways, regardless if this was instituted in this bill or not? Isn't that part of the process if a patient wanted to get an IUD? Can you describe that process?
Well, for the record, this is Sandra Koch, and yes, that discussion takes place. You would never do any kind of a procedure on any patient without a full discussion, all questions answered, consent signed if it's necessary, prior to a procedure.
Thank you so much. And just for general interest, what is a training process if a physician or APRN wanted to learn, say, on the insertion of an IUD, and maybe they haven't gotten that training before? Are there certain requirements, or is there a certain expectation so that they can understand how that process works? Is that something that has been established?
For the record, this is Sandra Koch, and for OBGYNs, the training occurs for these in residency program for IUD placement. I mean, we place so many of them during that period of time that everyone has proficiency there. The placement of the Nexplanon is actually a course that you have to take and be signed off before you can place them. And for APRNs, that's going to be a situation where they're learning. They need to become comfortable with it through an in-person training. They also need the requirement, they also have to meet the same requirement for the implants, but for the IUDs, that's not necessary. It's something that they're trained for if they become an OBGYN nurse practitioner. They learn how to do all sorts of intrauterine procedures.
Sounds great. Thank you so much. That pretty much covers my questions. Any other first questions? We'll go ahead and move on to support testimony. Any folks that would like to begin for support of Senate Bill 280 are encouraged to please come forward. We'll start with support, then opposition and neutral. So as a reminder, please keep your remarks to 2 minutes each, and we'll start with this gentleman first.
Good afternoon, Mr. Chairman and members of the Senate Health and Human Services Committee. My name is Dr. Tim McFerrin. I've been a practicing OBGYN for over 35 years. That's why the gray hair and loss of it. And also have been involved with public health for about 15 years, public health sector for about 15 years. What a novel idea. A woman goes to the hospital, has a baby, comes home with a 5-year contraceptive in place. I think everyone can see the benefits of this. In fact, it's been put into legislation by the ACA and also by this Nevada Legislature that long-acting contraceptives be provided to women at no cost. However, the insurance companies have found a loophole. Hospitals don't carry IUDs or long-acting contraceptives because insurance companies will not reimburse hospitals as an inpatient procedure. This is denying women access after childbirth to long-acting contraceptives. So I fully support Senate Bill 280. It closes the loophole and allows women access to long-acting reversible contraceptives in the hospital setting. Thank you.
Hi, this is Lindsay Harmon. I'm the Executive Director for Planned Parenthood Votes Nevada, and we're going to keep our comments very short and say that we are in support of SB 280 today and are happy that Dr. Koch has brought this forward to the committee.
Hello, Elise Monroy Marsala with Bells and Case Government Affairs, here today on behalf of the Nevada Public Health Association. The Nevada Public Health Association supports this bill. Ditto. Thanks.
Good afternoon, Chair, committee members. Sarah Watkins, representing Nevada State Medical Association. Our association supports SB 280 as it helps provide better access to care. As Dr. Koch provided in her presentation, this will improve the quality of care to patients that are unable to receive appropriate care after hospital discharge. We thank the Senator for bringing this bill forward. Thank you.
Good afternoon, Sarah Adler, again here for NAPNA, the Nevada Advanced Practice Nurses Association. NAPNA is a strong supporter of this bill because of what you have already discussed, the difficulty in achieving the follow-up visit for many underserved Nevadans. So being able to receive the long-acting reversible contraceptives at the time of birth will be greatly beneficial to our most vulnerable Nevadans. Thank you.
Thank you so much. Anyone else in Carson City, in Las Vegas, and virtually?
You would like to testify in support of SB 280? Please press star 9 to take your place in the queue.
Hello, my name is Caroline Mello-Robertson. I'm the Southwest Regional Director, here to register my support. I've submitted written comments and I'm going to save my voice. So thank you to the bill sponsor for bringing this issue forward. Thank you.
Hey, I'm Matt Walker, Administrator of White Pine County Hospital District in Ely, Nevada. I am also in support of this. The one concern I would have is Medicaid doesn't pay for implants, so they won't pay for it. So that's something to look at, but we do support this and think it's a great idea.
Good afternoon, Chair and members of the committee. For the record, my name is Shelby Swartz. I'm calling in staunch support of SB 280 because our hospitals need to ensure they are able to provide IUDs to any patient requesting it, especially post-birth. I am currently pregnant and keenly aware of how necessary birth control access is in the crucial period following childbirth. The insertion of an IUD post-delivery can provide women the crucial peace of mind during the intense and confusing postpartum period. Some people are actually more fertile after the birth of a child, and lack of access to birth control can spell disaster for a new parent who needs to focus on their brand new baby. We know that access to reliable, effective birth control is liberating for individuals and helps them protect their bodily autonomy. This is why I'm calling in today to support SB 280 and to urge the committee to support this bill. Thank you.
If you are calling to provide support testimony for SB 280, please press star 9 to take your place in the queue.
Hello,
Caller,
my name is Faye Rep. Hi, my name is Faye Repke, and I am a family medicine and obstetrics physician in Elko, Nevada, teaching family medicine residents and medical students. Being able to provide and teach how to insert IUDs and Nexplanons in the hospital is a really crucial task for our residents to provide comprehensive care. When I trained as a resident in California, we did have access to all types of contraception in the hospital, and we were able to provide immediate postpartum contraception, whether it be IUDs, Nexplanons, Depo, or any other option that women wanted. It provided comprehensive training for us and excellent care for our patients, and something that Nevada residents definitely deserve. Thank you so much.
Chair, there are no additional callers for testimony at this time.
Thank you so much. Anyone in opposition? Please proceed.
Good afternoon. Joan Hall, Nevada Rural Hospital Partners, here sadly in opposition because I believe in the premise of this bill, but as you heard earlier, only 3 rural hospitals have OB units. So if we could change the word at a hospital to add an OB unit of a hospital, that would work for us. But the patients delivering in our ERs and wanting this service, I'm not sure that it would even be safe for the ER providers to do the insertions. They're ER docs, not family practice or not obstetrics. So just that little change, and I'll work with the sponsor. Thank you.
Thank you so much. Anyone else in opposition in Las Vegas and virtually?
Chair, there are no additional callers to testify at this time.
Thank you so much. And last but not least, we'll go to neutral. Is there anyone in neutral in Carson City, Las Vegas, and virtually?
Chair, there are no callers choosing to testify at this time.
Thank you so much. Senator Nguyen, do you have any closing remarks? All right. At this time, I will go ahead and close the hearing on Senate Bill 280. And our last agenda item is public comment. If there's anyone in Carson City, anyone in Las Vegas, and virtually.
Chair, the lines are open and working, but there are no callers at this time.
Thank you so much. We have a meeting on Thursday. It will be great and long. And we have 2 rooms dedicated to it, so we expect everyone to be there. Thank you so much for joining us, and meeting's adjourned.